Greetings again, everybody, and welcome to case study number 43. This will be a set of parents coming in asking, why is my kid not gaining weight? If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button on the upper right-hand corner. I very much appreciate all the contributions that I can get to help offset the cost of these videos, and I thank all those of you in advance who have already donated. I appreciate it very much. Okay, we got a 12-month-old white boy coming into the clinic with his parents, and they're concerned that he's not gaining weight properly. He was born at term with APGAR scores of 7 and 9. Prenatal and birth history were uncomplicated. He was born at term, I already said that, and his birth weight was 8 pounds and 10 ounces. 8-10. He's achieved all developmental milestones at normal points. He's got 2 siblings. Mom says that occasionally he has very slimy stools compared to what his 2 older sisters had when they were babies. Review of systems is unremarkable. Mom says that he has a great appetite and particularly enjoys bananas, crackers, avocado, and whole milk. So this is not a picky child. Upon review of his postnatal course, notice that he passed meconium at 28 hours. When do we expect a child to pass meconium, a neonate? Less than 24 hours. Okay, so this is a delayed passage of meconium. He's been seen for 2 separate sinus infections. His weight is currently 20 pounds, which is the 29th percentile, so normal. Length is 29 inches, so 19th percentile, lower end, but still normal. He's on no medications and his vitals are within normal limits. So what do we know about pediatric weight gain in the infant period? So we know by 6 months, but usually a little sooner than that, you should double your weight. And by 1 year, you should triple your weight. So he's 1 year old, so what do we expect his weight to be? Well, he was 8 pounds, 10 ounces. So by now we would expect him to be about 25 to 26 pounds. He is 20 pounds, so he is not gaining weight properly, and that's called failure to thrive. Okay, so we got a child with failure to thrive, a history of delayed passage of meconium, and this kind of chronic sinus infection issue going on. All right, so our physical exam is pretty much normal, except we hear some light crackles and wheezes that are scattered, but everything else seems to be normal. What are we going to do now for our workup? Actually, what are we going to do? What's our differential? So you should have one thing sticking out in your mind here, and that is cystic fibrosis. Now, other causes of malabsorption can be considered. Celiac disease is a big one. Shwachman-Diamond syndrome is a rare cause. And then we have these other things that may cause that those crackles and wheezes that we heard, but they don't really explain malabsorption. So I want you to pay close attention to this growth chart here. We're always going to be looking at growth charts all the time in the clinic. Notice that he started right here, and he's crossed percentile lines. And what that means is that he is not growing properly. And we already did a case study where we went over growth charts ad nauseum, but it's important to understand that one of the major causes of losing weight percentiles is malabsorption and chronic diseases. Okay, so we're going to get a CBC, a BMP, a chest X-ray because of those abnormal findings. We're going to get a fecal fat test because of the possible malabsorptive process going on, and we're going to get a sweat chloride test because we were considering cystic fibrosis. And what do we find? Fecal fat test is positive, and the sweat chloride test was 79. It's abnormal if it's above 60. So we have a presumptive diagnosis of cystic fibrosis and a secondary failure to thrive. The management is supportive and it's based on the manifestations. The best initial and the most specific test for cystic fibrosis is the good old sweat chloride test. It's been around for a long time, still the best test. The management in this child is going to be to tend to the malabsorption. He doesn't have any pulmonary infections right now. We don't need to do anything about that. However, we will refer him to a cystic fibrosis care center. But as far as your management as a primary, you're going to be tending to the chief problem, which is malabsorption. So we're going to replace the pancreatic enzymes because all those enzymes in the pancreatic secretions, they're stuck. They're not getting into the intestine, so we need to give pancreatic enzymes. We'll also need to replace fat-soluble vitamins. Those are A, D, E, and K. We'll counsel the parents. We need to repeat the sweat chloride test. Why? Notice I said presumptive diagnosis. That's because you need to get 2 abnormal findings in order to really make a formal diagnosis. And then we'll send him off for genetic testing. That's going to be important in a little bit. We'll see why. So cystic fibrosis is a genetic disorder. It's autosomal recessive, and it's due to a defect of the chloride channel. Basically, what this results in is very thick secretions. And that's going to be a big problem when it comes to the GI tract because of those pancreatic secretions not getting into the intestine. And the pulmonary system, because remember, we need mucus, that whole mucociliary elevator tract, to be able to get rid of bacteria and pathogens. And so because they're unable to do that, they end up with recurrent infections, lower respiratory tract, upper respiratory tract, and so forth. So usually cystic fibrosis is picked up on newborn screening. However, there are a lot of mutations that can lead to CF, and not all of them are tested. So occasionally some fall through the cracks and we don't diagnose them until later on. Some clues include what we saw in this kid, a failure to pass meconium within 24 hours, a high appetite but poor weight gain. These kids will have voracious appetites because they're malnourished. They'll eat and eat and eat, and they can't absorb those nutrients. And so because they have this malabsorption, a lot of times they'll have bloating and flatus after meals because it's malabsorption. That always happens with malabsorption. They tend to get frequent pulmonary infections or sinus tract infections, and they may have a family history, but that can be difficult because remember, this is autosomal recessive. So if you do see if you do see a family history, it's going to be in siblings. The management is symptomatic. Routinely, we do chest physiotherapy, mucolytics. We use Dornase alpha, inhaled hypertonic saline, annual influenza shots. Make sure they're pneumovaxed, and then inhaled tobramycin later on in the course as a prophylaxis. For acute exacerbations, we use antibiotics, steroids, and albuterol. And for the malabsorption, we do enzyme replacement and vitamins. Now, there are these chloride channel modulators, and they can slow progression of cystic fibrosis. They're very frequently part of therapy. The problem, and the reason you probably won't be asked about this, is which ones that you use, if any, is going to depend on the precise mutation. That's why we send the kid off for genetic testing. We know he's got CF, but we need to know the exact mutation to help guide our therapy. The treatment of pulmonary exacerbations is antibiotics, physiotherapy, albuterol, Dornase, and steroids. Now, what antibiotics we use is going to depend on the exacerbation. So if it's a mild exacerbation, we can use oral amoxicillin clavulanate. There are other drugs we can use, but typically we go PO for mild exacerbations. If it's a moderate or severe exacerbation, or they have a documented history of Pseudomonas, then we need to go for dual therapy. Typically, we'll always do tobramycin, and then we add another antibiotic on top of that. Oftentimes, it'll be piperacillin tazobactam. You can also use linezolid. It really just depends on sensitivities and what you've done before, but those are both correct answers for your exam. You just got to make sure you have Pseudomonas coverage. Now, what's mild, what's moderate, what's severe, just depends on their deviation from baseline. So it's a clinical judgment call. There's really no criteria. These are the pathogens. So as you can see here, as you get later on in life, Pseudomonas becomes more common. So that's important to recognize. These are some of our common differentials. You should be able to understand why these differentials were not the right answer. Obviously, only cystic fibrosis is going to give you an abnormal chloride channel manifestation. So it's the only one that's going to give you an abnormal sweat chloride. So to recap, CF is a genetic disorder caused by a defect of the chloride channel. It is multisystemic, but primarily affects the pulmonary and GI systems. Most patients will become symptomatic at birth or shortly after birth with these repeated respiratory tract infections, poor weight gain. Those are the two most common ways that CF patients will present. It should be suspected when there's failure to pass meconium within 24 hours, if there's a persistent productive cough, if there's failure to thrive with steatorrhea, or if they ever get rectal prolapse. Some clues that may clue you in on CF is nasal polyps, just due to the chronic mucosal inflammation of the upper respiratory tract, a salty child, recurrent infections, or malabsorption. And the management for CF, as mentioned, is symptomatic.